So what I'm going to do today is to talk about improving CKD patient health, subtitled We Have to Do Better, and We Can. I have no relevant financial disclosures. I do have to tell the physicians in the room that I'm on the American Board of Internal Medicine, Nephrology Specialty Board, and exam writing committees. Nothing I say will help you prepare for the boards. Sorry. So does anybody know what this is? I'll give you a hint. It's not a hamburger. So for any of you who might be involved in education or in particular medical education, you often hear the term the feedback sandwich. So that's what this is. This is a feedback sandwich. And the point of giving feedback, or one of the instructions we give about giving feedback to our trainees, is you tell them something good. That's the top bun. And then you give them the bad news, the meat of the sandwich, and then you give them some good news again. That's the bottom bun. So that's sort of how I've organized my talk for this afternoon. And we'll start with some good news, the top bun, which is some things that have gone well in nephrology and the care of patients with kidney disease over the last decade or so. So the first top bun bit of news is shown here, looking at end-stage renal disease incident rates. So this is the occurrence of new cases of end-stage renal disease, patients starting dialysis in the United States. This comes from the USRDS 2014 report from data showing up to 2012. And you can see some pretty exciting and interesting things have been happening over the last few decades. So we see a leveling off in the incidence of end-stage renal disease in white patients and Caucasians and in Asian patients, an extraordinarily dramatic decline in the incident rates among Native Americans, and in the highest risk group in the United States, African Americans, a leveling off, and in more recent years, a decline in the incidence of end-stage renal disease. And we can see that this is affecting a variety of different age populations, most dramatically in the high-risk older age group of 75 and older, as well as those 65 to 74, with a leveling off of the incidence in younger patients as well. So we're doing something right, it seems, in reducing the development of end-stage renal disease. And perhaps even more exciting is the fall in the mortality rate among patients with end-stage renal disease in the United States. This is again from the 2014 USRDS report, and we can see that in all patients with end-stage renal disease, that includes hemodialysis, peritoneal dialysis, and transplant patients, there's been a decline and then a leveling off of mortality and then a further decline. And we can see this in each of the different patient population groups, most notably in peritoneal dialysis patients, but in hemodialysis patients as well. Since this is the NKF meeting, I can't help but point out that in 1997 was the first NKF, then DOKI, subsequently KDOKI, clinical practice guideline. And a couple of years after that and other guidelines came out, the leveling off here turned into a further decline in mortality. I'm not saying this is cause and effect by any means, but I'm just saying. So now let's turn to the meat of the matter, and I want to talk about several different areas about the care of patients with kidney disease and the preparation of patients with chronic kidney disease for renal replacement therapy, where I think maybe we can do a little bit better. This is looking again from the USRDS report on the initial dialysis modality. So people are first starting dialysis with either hemodialysis, peritoneal dialysis, or a transplant. And just to give you some perspective, in 2012 there were slightly over 100,000 patients who started dialysis in the United States. As I've shown here, fewer than 500 of them started with home hemodialysis. There are fewer than 10,000 patients who started with peritoneal dialysis. So over 90% of patients in the United States who start dialysis start with in-center, conventional, typically 3 times a week hemodialysis. I'll return in a couple of minutes to contrast this with what nephrologists would choose for themselves if they needed to start dialysis. So what underlies this? What are some of the things that might explain this? This is a paper from 2008 by Dr. Finkelstein, who is probably in the audience here somewhere. I know he's here at the meeting. that looked at using a survey in over 676 patients, or over 670 patients with stage 3 to 4 CKD, what they knew as they reported on a survey about end-stage renal disease therapies. So 43% had no knowledge of hemodialysis, 60% no knowledge of peritoneal dialysis, slightly more than half no knowledge of transplantation, and about a third had no knowledge of any modality of therapy for end-stage renal disease. Many of the patients did not understand the advantages and disadvantages of any of these different modalities. And even with late-stage CKD, patients who had CKD stage 5, as many as a third had no knowledge of one or more of these ESRD therapies. Even with 4 visits to a nephrologist, or 4 or more visits to a nephrologist, a third had no knowledge of hemodialysis, and a half had no knowledge of peritoneal dialysis. So clearly, substantial room for improvement. I would point out that Dr. Finkelstein will be receiving the J. Michael Lazarus Award tomorrow. Who influences modality selection? Well, a lot of people, potentially. Obviously, the patient has a large say in the choice of their modality, the nephrologist, the information they provide, primary care doctors, dialysis nurses, providers, other nurses, CKD educators, family, and friends. So this is a complex interchange that takes place as patients approach the need for renal replacement therapy. I think it's informative to hear from the patients what they say about dialysis and what it means to them. This comes from a nursing journal paper from 2013, taking some patient quotes about what they thought about this process of beginning dialysis. The only thing the doctor said that I was going on dialysis, I didn't have a choice. I'd like to stay as normal as I can. Hemodialysis would be less disruptive of our life. I don't want it at home. I don't want to be reminded of having an illness. Peritoneal dialysis is better because I can work. Home dialysis gives me a bit more freedom. And if I can't have a semblance of normal life, then why would I want to live? So it's important, as we take care of patients with chronic kidney disease approaching the need for renal replacement therapy, that we hear their view, that we hear their perspective, and help them adapt to what might be a new change in their lives that's rather dramatic. It's also interesting to look at what happens to people who choose one modality over another, and from that time to the time they actually start dialysis. This was a paper published in American Journal of Kidney Disease coming out of the University of Rochester. And hopefully you can read this. This is a group of patients who received dialysis modality education before starting dialysis, and then subsequently started dialysis. About a little bit more than half of the patients in this cohort chose peritoneal dialysis, 124 of the 217, whereas 93 chose to do something other than peritoneal dialysis. Of this group, the 93 that chose not to do peritoneal dialysis, the majority that chose hemodialysis started on hemodialysis. Those that were undecided mostly ended up doing hemodialysis as well. What's a little bit disconcerting for somebody like myself who thinks that peritoneal dialysis is a good dialysis modality, of the 124 who chose peritoneal dialysis, the initial modality was hemodialysis in somewhat more than half. And at 90 days, only just slightly more than half were on peritoneal dialysis. So about a 50-50 likelihood of being on peritoneal dialysis at 90 days and beyond, when that was the modality that was selected for the patient. So clearly there's a disconnect between what the patients express as their desire for renal replacement therapy and where they end up. So now I'll return to the point I made, or that I suggested I was going to come back to a few minutes ago, and what do nephrologists choose? So again, reminding you that 90% of patients that start dialysis in the United States start on hemodialysis. And of those who start in-center hemodialysis, the vast majority will remain on in-center hemodialysis for the rest of their lives. In this survey of 600 nephrologists, 45% said that they would choose peritoneal dialysis, 18% nocturnal home hemodialysis, and 25% daily home hemodialysis, and only 6% said that they would choose in-center hemodialysis. So completely opposite to what we do with our patients. So I think it's an area for improvement. There is some good news. Home dialysis prevalence seems to be increasing. This is from USRDS. This is number of patients in thousands. So we can see that beginning about 10 years ago or 8 years ago, there was an increase that began in the use primarily of peritoneal dialysis, but some in home hemodialysis as well. And this has continued in more recent analyses as well, and we'll just have to see over time whether this is sustained. But I think there's opportunity here then to help our patients start on the dialysis modality they want to start, help them get more informed, help them understand the advantages and disadvantages of different dialysis modalities, and then facilitate the start of dialysis with their preference. And I would think that their preference and what we start our patients on should to some extent mirror what we would want for ourselves. So another area that's of interest and of concern in the care of patients with chronic kidney disease is identifying those who have chronic kidney disease with the purpose of, among other things, being safe with drug prescribing behaviors in this patient population. So this was a paper that was recently published by a former president of the National Kidney Foundation, Linda Sezek, that did a multi-center observational study of over 9,000 individuals, adults with type 2 diabetes mellitus, looking at what was happening in their primary care practices. This is the percent of patients that were identified as having chronic kidney disease among all stages 1 through 5, 1 to 2, so only 3.4% of those were identified in the charts as having CKD. In later stages 3 to 5, only 21% were identified in the chart as having CKD. And actually nearly half of primary care physicians did not identify any of the patients in their practices as having chronic kidney disease. And of those who had chronic kidney disease in the 15 months prior to this study, 15% did not have an EGFR and over half did not have a urine albumin or protein test. So clearly a problem in identifying patients with CKD in primary care practices. I've mentioned already Dr. Sezek. Some of these other names will be familiar to you because they've done other work with NKF, as well as Dr. Vasilati, who's the Chief Medical Officer of the NKF. So lots of opportunity to increase the awareness among primary care providers about CKD patients. And why does it matter? I'm going to focus here just on the issue of medication safety. This is a paper that came out from Dr. Plantinga in 2011. They looked at reported current use, defined as nearly every day for the last 30 days or more among patients without CKD, CKD stage 1 or 2, and 3 or 4. Quite surprisingly, among patients with CKD, NSAID use was more common than it was among patients without CKD, and this was mostly all related to over-the-counter use. And of those who reported current NSAID use, the vast majority of them, about 2/3, were actually taking NSAIDs for a quite long period of time, for a year or more. So I see this as a function of the role that should be provided by primary care providers to some extent. You can't tell your patients to avoid medications that should be avoided in those with CKD unless you identify them as having CKD. And we should be helping our primary care physicians, and the NKF is launching a major initiative to do so, to help our primary care physicians recognize the presence of CKD in their patients. It goes beyond just NSAID use. This is a paper from last year in American Journal of Kidney Disease looking at antibiotic dosing errors in patients with chronic kidney disease, late stage, stage 4 or 5, who are 66 years or older. And you can see here, I won't go through all the details of this slide, the percentage of prescriptions that had a dosing error. And it was pretty common. Nitrofurantoin, for those of you why 100% would be wrong, is contraindicated in patients with this degree of kidney dysfunction. So very common medication errors in this group of in this patient population. So they looked a little bit further in this study as to what was the likelihood of having an error in dosing prior to automated EGFR reporting, and it was 64 out of 100 prescriptions, so quite common. After EGFR reporting, 68 out of 100 prescriptions had dosing errors. So clearly we have lots of room to improve. And even among transplant recipients, medication errors are common. This was a paper published also last year. Nearly 2/3 of transplant patients experienced at least one medication error. Most of these actually were patient errors, taking the medicine incorrectly, skipping medicines, and so forth, but 17% were pharmacy errors and 15% were prescribing errors. And of patients who experienced a medication error, they were more likely to have a hospitalization, an adverse drug event. There were higher costs of care and reduced graft survival. So very serious consequences from medication errors in this patient population. So here I think the points are we need to do better with helping our primary care providers, and I include in primary care providers both physicians and advanced practice nurses and others who are involved in the primary care of CKD patients. We need to help them identify their patients with CKD, and we need to help them understand, and the patients understand, what medications should be avoided, and that there needs to be attention paid to the dosing of medications in this vulnerable patient population. I'm going to move on and talk about health literacy and the information that we provide to our patients with chronic kidney disease. So health literacy is defined as the degree to which individuals have the capacity to obtain, process, and understand basic health-related information so that they can use that to prevent and treat illness. And that's sort of a general definition of health literacy. As you see in this slide, limited health literacy, which is variably defined, but it's the inability to understand and comprehend this material, is very common among patients with kidney disease, and particularly those with more advanced stages of kidney disease. And in other studies besides this one, as many as 20 to 30% of CKD patients have been found to have limited health literacy, which some studies will define as being at the 5th or 6th grade reading level or below. So how do we do in terms of providing educational material for our patients that fits their health literacy, that's at an appropriate level for them to read and understand? So this was a very recently published paper from the American Journal of Kidney Disease, where they looked at a variety of different educational materials that had been prepared for patients with CKD. These are two different scales of readability. This is a grade level, and this is what's called the Lexile score that roughly corresponds to grade levels. And I've put arrows here to show you what I think most people in this business would consider to be the upper bound of readability, and probably a more recommended level at the 5th grade level as opposed to the 8th grade level. And you can see in these histograms that the vast majority of the written material is, the majority of it is above the 8th grade level. And as you can see here, virtually all of it, almost 100% of it, was written above the 5th grade level, hence not very comprehensible to many of our patients whom we're trying to educate about chronic kidney disease. There was another paper that came out in the Nephrology Nursing Journal looking at websites that provided kidney disease education, and only 3 were rated as having fairly easy readability. There's other literature in this area. This was published in the American Journal of Nephrology in 2013, and they assessed materials that addressed a variety of different aspects of chronic kidney disease, the basics, risk factors for CKD development and progression, complications of CKD, and self-management strategies. This may be presented a little better overview or a better assessment or a more favorable assessment of what was available, and they rated most of the materials as adequate. Only 20% were superior, and the outstanding materials were notable for being patient-centered, to being focused on patients who have low literacy, and to have patient interaction. It was reassuring to see that the NKF had material in the top 5 for each of these categories. All were written at the 6th grade reading level or below. So there's a lot of literature out there. A lot of the literature from the NKF is really outstanding. This is just one example of a patient education material adapted from the National Kidney Diseases Education Programs, I'll point out, that very simply and with some graphics explains what kidney tests are, how the kidneys are checked, what your kidneys do, what the GFR tests are, and so forth, in a very simple way without huge amounts of text on the page. And it's examples like this that we need to have available to us to help take care of our patients. So to wrap this little part of my talk up, I think that we need to do a better job of educating our patients. We need to make sure we have educational material, whether it's web-based or printed, that's available to them that they can understand, including understand if English is not their primary language, and we need to help them to understand what we're giving them and answer the questions that they have. And then finally, the next part of the hamburger, if you will, that I'd like to address is, are we starting dialysis too early? This is an area that's been a matter of some debate and lots of emotion over the last few years or so. When I was a renal fellow back here somewhere, I won't be too precise about it, it was almost unheard of to start a patient on dialysis when the GFR was greater than 10 mLs per minute. We didn't talk about GFR in mLs per minute per 1.73 meters squared then. So thank you, Dr. Levy. We do now. So what you can see has happened over the years is the eGFR at the start of dialysis has increased on average, with now 15 to 20% of patients above 15 mLs per minute, a large group of patients in the 10 to 15 range. So in 2012, 40% started dialysis with an eGFR greater than 10 mLs per minute per 1.73 meters squared. And again, I'm not arguing that this is the right thing or the wrong thing to do. We do, as many of you know, have one large randomized controlled trial suggesting that a specific number isn't necessarily the right target for starting dialysis, but we can wait for patients to become symptomatic. I would argue, though, that if we delay starting dialysis a little bit, we could at least make some good use of that time, modality education, preparing them for the modality that they've selected, getting an access in instead of a tunnel dialysis catheter like so many of our patients have now. So we have to ask then, would later be better for some of our patients? As I've said, about 40% of our patients start dialysis with eGFRs above 10, and about 40% of patients start dialysis without prior pre-dialysis nephrology care for a variety of different reasons. If we can take care of these patients before they start dialysis, take advantage of that last 5 mLs per minute of GFR, it creates opportunities for modality selection, access placement, whether it be vascular or peritoneal, blood pressure control, anemia management, shared decision-making, and a better understanding of goals of care, and initiating transplant evaluation. And this is just the data from one of now many studies that have come out, generally, in fact, almost all retrospective observational studies, suggesting that there's not a mortality advantage of starting early. In fact, in retrospective observational studies, not all of them, but some, there appears to be a mortality disadvantage of starting early. There's a variety of reasons for this. It may not be true. It may have to do with a variety of biases, or just starting sicker patients earlier, but it should, I think, give us pause. And why do we start patients early? Some of it, I think, relates to clinical practice guideline advice. Some of it is for symptom management, although I think we should be mindful that uremic symptoms are rather nonspecific, and we need to carefully avoid starting people on dialysis who have symptoms that are not likely to be improved by dialysis. And then I think a lot of it is that it's easier to start the patient on dialysis oftentimes than manage their many complex problems in the office, where in the dialysis unit there are nurses, dietitians, social workers, pharmacists, and many others who can assist in the care of these patients. And then there may be some monetary issues as well, although we probably shouldn't talk about that. Is it okay to show a picture of President Obama in Texas? I'm not really sure. But... All right, so let me return to the bottom bun. I've pointed out some things where I think there are opportunities for us as nephrologists and others involved in the care of patients with kidney disease to do better. And I want to finish with some examples where we are doing better, that people are demonstrating the ability to be collaborative and to improve the things that they do for the patients. And I want to use that as, if you will, a trigger for all of us, for everybody in the room, as you leave here, as you go back to your homes and take care of your patients with kidney disease, to think about ways that you can do better for the care of your patients. If we all, however many of us are in this room, do just a little bit better helping our patients manage their chronic kidney disease, prepare for dialysis, I think we'll do a world of good for this patient population. So this was a paper that was published just recently in the American Journal of Kidney Disease. This was a multi-center collaborative effort between a group of 9 primary care practices and 5 nephrology practices in Philadelphia and Chicago, where they used a toolkit derived from the Renal Physicians Association to put together some guidelines for care of patients with CKD. And the results of the study were that in a relatively short period of time, they improved the identification of chronic kidney disease by primary care providers, enhanced appropriate nephrology referral, and improved communication between primary care physicians and nephrologists, as well as co-management processes. They increased awareness of CKD risk factors and guideline recommendations for care, and improved primary care provider and nephrologist satisfaction. So, good effort there. This was another paper that came out of Taiwan looking at the effects of an NKF Keidoki-based CKD education program in 245 patients who had chronic kidney disease that progressed to end-stage renal disease, and they started dialysis. The patients were previously randomized, before they started dialysis, to randomized care prior to starting dialysis, or a multidisciplinary pre-dialysis educational program, which, as I mentioned, was based on NKF Keidoki guidelines. And what they found in the first 6 months after starting dialysis was actually rather dramatic. There was lower total and inpatient costs per patient. Fewer patients were admitted. There were fewer and shorter hospitalizations, fewer cardiovascular disease admissions, fewer hemodialysis access operations, and lower physicians' fees. So again, a good example of how a relatively simple intervention can have a substantial and dramatic impact on patients in a relatively short period of time. And then finally, this paper that was published in Kidney International last year looked at a comparison of patients who did not participate in the Kidney Early Evaluation Program, or KEEP, community-based screenings, and those that did before starting dialysis. And among KEEP participants, there was a higher rate of pre-dialysis care by a nephrologist, a higher rate of peritoneal dialysis use. Patients were more likely to be on a kidney transplant list before they started dialysis, were more likely to get transplanted, and had a lower mortality risk. So again, huge impact on this vulnerable patient population with a relatively simple intervention. So I'd like to conclude by reminding all of us that much has been done that has improved the lives of patients with kidney disease. We have a lot to be thankful for and grateful for. We've done a lot for patients over the decades with chronic kidney disease, but there is more that we can do. We can work with our primary care providers to improve CKD identification and improve safe prescribing in patients with chronic kidney disease. We have to educate our patients and families about chronic kidney disease and renal replacement therapies in language that they can understand at an appropriate grade level in the appropriate language. We should ensure that our patients have access to all renal replacement therapy modalities, including those that we would choose for ourselves. In-center hemodialysis should not be the automatic default modality for initiation of dialysis, as it all too often is. And we need to help patients to start renal replacement therapy better, not just early. And anything else that you can think of that might improve the care of these patients with chronic kidney disease, please do so. Thank you very much.